Bismillahirrahmanirrahim. So again, starting with the retinal detachment. Last time we discussed briefly about the retinal detachment, and now again a quick review what we discussed in direct ophthalmoscopy, B-scan ultrasonography. If the posterior segment of the eye is not visible, then the normal anatomy of the eye. Okay, this is a new picture, and it shows the retinal layers. This is the optical coherence tomography of the eye. This is the optic nerve. These are the different layers of the retina. These are the vascular complexes of the choroid. Then we know that anatomically that after choroid there is the retinal pigment epithelium. The retinal pigment epithelium, after the retinal pigment epithelium, there is the photoreceptor layers. Then the photoreceptor layer of rods and cones. Then the external limiting membrane. Then the outer nuclear layer, outer plexiform, inner nuclear, inner plexiform layer, ganglion cells layer, retinal nerve fiber layer, and the innermost one is the internal limiting membrane. So what will happen and the retinal detachment? Retinal detachment, I told you last time that actually it's the entry of there is a break formation in the retina, and when the break is formed, the fluid from the vitreous cavity goes through that break and it goes and it detaches the neurosensory retina from the retinal pigment epithelium. Then types of retinal detachment. Another point I would like to mention that after completing of the lectures of the retina, because we will discuss different types of retinal detachment, and after that, there will be an assessment of few people, and that will be live uh, about the retinal detachment, and then that will be entered into the assessment of few people, so that we should know that how you people understand it. So there will be assessment after 4 or 5 lectures. I will try to finish the retinal detachment within this time. Then I will let you know. So there are different types of retinal detachment. Mainly, we are classifying it into 3 types. That is the rhegmatogenous, tractional, and exudative type. Rhegmatogenous, rhegma means break. If there is break in the retina, that is called rhegmatogenous retinal detachment. If there is traction on the retina, traction means like in patients with diabetic retinopathy, if there is vascular occlusion, any proliferative disease in which there is vascular proliferation into the vitreous cavity, and those vessels, because these are the retinal vessels which are invading into the the vitreous, and with the passage of time it gets fibrosed because these are the retinal vessels and it is growing into the vitreous. With the movement of the vitreous there will be traction on the retina and it leads to retinal detachment, and that is called the tractional type of retinal detachment. Then exudative type, there is no break, and actually it is because of the exudation of fluid from the choroidal side, because usually the RP pumps the fluid out and it's not allowing the fluid into the subretinal space. So what happened an exudative type of retinal detachment, that barrier is compromised and the fluid from the choroidal side can get entry into the subretinal space leading to the retinal detachment. But it is not the fluid which is going from the vitreous cavity, it's actually coming from the choroidal side. And the exudative retinal detachment usually occur in patients with inflammatory diseases or with the tumors. So we can see cells and the vitreous cavity, but these are not the brown cells which are coming from the retinal pigment epithelium, but actually these are the inflammatory cells. And another type, that is the combined tractional and rhegmatogenous retinal detachment. Like if a patient with diabetic retinopathy, there is traction on the retina, and with pulling of the retina, a break is formed. Then it is called combined tractional and rhegmatogenous retinal detachment, because rhegma means break. If the break is formed, it is rhegmatogenous. But if it is because of the tractional component, then it is called the rhegmatogenous, combined tractional and rhegmatogenous retinal detachment. But broadly, the retinal detachment is divided into rhegmatogenous, tractional, and exudative type of retinal detachment. We discussed it last time, that what happens normally, there is a small lacunae is formed within the vitreous cavity and it collapses and together, and because of the liquefaction of the vitreous cavity, because of the breakdown of the collagen fibers within the vitreous cavity, there is breakdown of the collagen fibers, and because of the liquefaction, the vitreous sinks down. The function of the vitreous is to act as a tamponade for the retina And when the vitreous sinks down, what happened that the tamponading effect is lost. And another significance of the vitreous detachment is, I told you last time, if it is strongly attached to some areas of degeneration, what it will cause, it will pull traction on that retina and usually break is formed. It, we discussed last time that there is the vitreous base. The vitreous cannot be removed from the base, and because it's very strongly attached over here, it is also strongly attached at the optic base, also along the major vessels. And normal mechanism of the posterior vitreous detachment is it starts from the perimacular region and from the optic disc. If any, this is called the normal posterior vitreous detachment. But abnormal, if it is abnormally adherent to some part of the retina, and that is then responsible for complications as well. We discussed it last time as well. So again, this is the normal posterior vitreous detachment. Normal posterior vitreous start detaching from the perimacular region, then from the optic disc it is detached and it goes anteriorly like this. And this the tamponading effect is lost, but if there is strong vitreous detachment to the retina, usually break is formed, not necessarily. Normally, no break is formed. But whenever the patient is complaining of floaters, flashes, then we need to examine the periphery of the retina for any break if we see that the patient has got posterior vitreous detachment. This is the optical coherence tomography of the patient showing uh, showing the normal vitreous detachment. I told you that usually the posterior vitreous start detaching in the perimacular region, then from the macular region, then from the optic disc. And when it is detaching, this is the optic disc, this is the macular region, and this is the face of the posterior vitreous that is detached from the macula and from the perimacular region. And at the end, it is also detached from the optic disc. Whenever it is detached from the optic disc, it take away some of the glial cells along with that. That is called white strings, and that white string is usually reported by the patient as floaters, that something is coming in my view. But that is actually these the glial cell which as a result that is avulsed from the optic disc by the process of posterior vitreous detachment. This is the normal PVD, posterior vitreous detachment. But whenever there is strong attachment, like in this case, because the vitreous is detached from the perimacular region, but in the center of the macula, it is still attached. If it is attached at the center of the macula, what the vitreous will do, it will move. It will also pull the macula, and the patient will be having metamorphopsia, micropsia, and all these things, abnormalities which are associated with the macular region, and ultimately a macular hole is formed if this traction is not relieved. And the treatment for this traction is the patient need to undergo pars plana vitrectomy and to remove this traction from the macular region. Again, and rhegmatogenous retinal detachment, what will happen that I told you that normally the vitreous is detached from the retina. This is the glial cell that is removed from the optic disc, and these are called white strings, and it is reported by the patient as floaters. Whenever the vitreous is strongly attached with the retina, because the vitreous will be detaching, and because it is strongly attached with the retina, what it will do is that it will form a break in the retina. When the break is formed, this fluid is then in continuation with that of the subretinal space, and it will go into the break, leading to the retinal detachment. And usually these areas of the retina, there is some sort of degenerations. And I mentioned in last lecture that these degenerations are actually the weak points of the retina, and the vitreous is strongly attached with this area. So during PVD, posterior vitreous detachment, it pulls the retina and form a break in the retina, and when the break is formed, the fluid then has a communication with the subretinal space, leading to the retinal detachment. Like here, because the vitreous is strongly attached to this area, and when it is detached, it also take away some part of the retina along with this and making a hole, and then the subretinal space is in continuation with this fluid, and then it leads to the retinal detachment. Again, we discussed it last time that there are different various types of degenerations. These are all lattice degenerations, snowflakes degeneration. These are breaks or holes within the lattice degenerations, and these are the weak area of the retina, and the vitreous attachment is strong for these regions. These are the different the breaks, U-tear. These are the degenerations. Again, we discussed it that mechanism of retinal detachment again. And okay, so that is the process of the retinal detachment. The fluid gets into the subretinal space and the retina is detached. This is the normal distribution of the retinal detachment that the upper temporal quadrant is most commonly affected, and mostly we find break in the upper temporal quadrant that is affected in 60% of the cases. Upper nasal quadrant 15%, lower nasal quadrant 10%, and the lower temporal quadrant 15% of the cases. So the most common location for the retinal break formation is the upper temporal quadrant, and that whenever the break is seen in this region, and if there is any retinal detachment, it's an emergency for treatment because what will happen? This is the upper temporal quadrant. The macula is also here on the temporal side. So what will happen that the fluid will go and it will detaches the macula, and we know that the sharp vision is on the macula, and the macula will be detached, leading to the loss of vision. Secondly, because it is the upper quadrant, so the fluid will gravitate inferiorly. Like let's suppose if there is a break in the inferior temporal quadrant, what will happen? The fluid cannot go superiorly, but because of the gravitational effect, the fluid will come inferiorly. So if there is inferior detachment, you can wait, you can see it's not an emergency, and you can wait for a few days. Again, it needs to be treated as early as possible. But superior upper temporal quadrant breaks or superior breaks are usually emergency because it will gravitate inferiorly, and within a day or so, it will lead to the macula off retinal detachment. Macula off means when the macula is also detached. Macula on retinal detachment when the macula is attached, but there is retinal detachment. We discussed it. Photopsia, floaters, tobacco dust. Tobacco dust are actually the retinal pigment epithelial cells which get entered into the vitreous cavity because of the break and the retina. Yellow pupil reflex because the normal red reflex is lost. Normal red reflex is from the choroidal vessels because the retina is detached now, so the the red reflex is lost. So let's suppose if there is a break in the retina and the retina is not detached, so the ideal treatment is that we should go as early as possible for the barrage laser. Barrage laser means that this is the retinal break and we need to surround it with the laser. We need to apply the laser all around the break so that this area, with the process of fibrosis, the fluid will not be able to enter into this break area and to detach the retina. So if the retina is not detached and you see a break, and if the vitreous is attached and the patient is symptomatic, means the patient is having floaters, photopsia, flashes, then it needs treatment. Whenever the patient is symptomatic and you see a break, it is an indication for the prophylactic laser because the retina is not detached. If you leave the break like this, without these are all the laser scars. Without the laser scars, what will happen? Because there is no fibrosis and the fluid will get entry into this break leading to the retinal detachment. But if you do laser, what will happen that there is fibrosis of this area of the retina and the break will be the fluid will not be able to enter because this area will be closed because of the laser spots. Again, you can see here is a large break and the retina. What you need to do, you need to barrage it, surround the until and unless there is no retinal detachment. If there is retinal detachment, the laser will not work because there will be no adhesion will be formed. There will be fluid and between the retina and the choroid, and this fibrosis is not going to take place. It's going to take place only if the retina is attached. We are applying laser to the attached retina, not to the detached retina. So the break is there, but the retina is not detached. It's if the patient presents early before the retinal detachment, then we can apply laser and we can surround the break with the laser spots so that the fibrosis is formed and this area is then closed and the fluid cannot gravitate inferiorly because of the laser. And if the retina is detached, then it needs surgery. The laser will not work. Again, you can see if there is a break is formed because it's a superior area, what will happen that the fluid will gravitate inferiorly. We can apply the laser is also being applied, and we can also apply cyclochiropexy from the exterior side. We can visualize this break with indirect ophthalmoscopy over here, and we can place a probe over here so that there is aseptic inflammation take place and the break is closed. Another option for the treatment of retinal detachment is Pneumatic retinopathy. Pneumatic means air, gas. What we will do in this procedure, let's suppose this is a break and the retina is detached. What we will do that we need to put some gas in the eye, and what will happen? The gas will expand. There are different types of gases used, SF6, C3, F8, and it depends on the, because some of the air will work only for a few days, for 5 days. The C2F6 will work for about 30 days, and C3F8 is another gas which can work for up to about 2 months. For 2 months, it will be there within the vitreous cavity. And again, it's usually we are putting the gas because with the passage of time it expands. So we need to calculate the concentration of the gas, that how much we need to give. Because what will happen if we give and the concentrated form, the vitreous cavity is about 4 ml space, and if we inject it in the concentrated form, it will expand with the passage of time, and the pressure will be too much raised, and there are chances of the vascular occlusion. So we need to calculate the amount of gas, how much we need to inject. What the gas will do, the gas will push this retina towards the choroidal side. This break will be closed. This break will be closed by this gas bubble. And what are the indications for putting gas in the eye is if the breaks are located superiorly. Let's suppose if there is a break that is located inferiorly, the gas is not going to tamponade this break. The gas is not going to tamponade this break because it's inferior. The gases are lighter, it will go up. If the break is superior, it's an indication, and it's a small detachment without traction. You can inject gas and it will be having tamponading effect, and the retina will be brought back to the choroid, and the fluid will be absorbed. So for indication of pneumatic retinopathy are the superior breaks, small breaks within a localized area, 1 to 2 clock hours, not everywhere. If the breaks are everywhere, what will happen? If there is a break inferiorly, that will not be closed by the pneumatic retinopathy because it is having tamponading effect superiorly. So what will happen? That the fluid will go through this break inferiorly, and the retina will be detached. So for the pneumatic retinopathy, there are certain complications of pneumatic retinopathy as well, because other breaks can also be formed. It's a complication of this procedure. Secondly, the cavity, it's not through surgical intervention because the cavity is already filled with the vitreous. And if we are injecting gas, what will happen? The vitreous, sometimes the vitreous pulls some other part of the retina, and a break is formed. But it's an office-based procedure. It's not a procedure like pars plana vitrectomy. It can be done easily. Just we inject within through pars plana, going through pars plana, and inject the gas. And what will happen? It will push the retina, and it will be detached. Not necessarily, because the success rate of the pneumatic retinopathy is lower than that of the pars plana vitrectomy, but it's a treatment options we can have. Then another procedure, because two types of retinal surgery can be performed, what is called the external retinal detachment surgery. The second one is the internal. The internal one is called the pars plana vitrectomy. The external one is called buckling. Some people call it DACE, D-A-C-E, means D means drainage, A means air, C means cryopexy, and E means explant. So and that procedure is done, that the conjunctiva is removed, the muscles are exposed, the break is already been identified with indirect ophthalmoscopy, that here is the retinal break. So what we will do, because the retinal break, there is subretinal fluid and between the RP and the neurosensory retina. So from the external side, from the scleral side, a small incision is formed that is called the sclerotomy, and this area is through sclerotomy we reach up to this area, because this is the subretinal fluid. The subretinal fluid goes out because the incision, a small incision is given in the sclera. The subretinal fluid will go out, and what will happen? We inject then air into the vitreous cavity, so the vitreous cavity is filled with air. The fluid has already gone, the subretinal fluid, through the sclerotomy, and we inject air within the vitreous cavity, so it will expand and the retina will go back and attach. Then if the break is if there is break, to the location of the break we apply cryopexy to produce aseptic inflammation to that retinal break, and that is closed, so the retina gets attached. And this procedure, the vitreous, it is the external procedure because we are not going into the eye to remove the vitreous cavity, to remove the vitreous. This is the encirclement band that is usually placed at the equator, and also it depends. It is usually placed at the equator, then it is stitched with the sclera so that an indentation is produced. Let's suppose if there is the break is then, sorry, so that the break is then closed by the indentation and it is tied, and again the conjunctiva is passed and stitched with the nimbus. It is passed through beneath the muscle, so there is no restriction of the extraocular movements. Definitely, it is also having some complications. It produces myopia because when it presses the eye, what will happen? The axial length of the eye is reduced, and it will produces myopia. Secondly, because it's an external approach, we are not going into the eye. Still, through external approach, external retinal detachment surgical procedure, it can be used. But again, when we will be going for the external approach, for the external retinal detachment surgery, and when we will go for the pars plana vitrectomy. If the patient is phakic and the patient is young and phakic, there is no cataract. It means, and it's an early retinal detachment. The posterior vitreoretinopathy process has not been is not been complex because there are posterior vitreoretinopathy is that we call it PVR. PVR is a proliferative process, and it usually starts after the traction, the rhegmatogenous retinal detachment. When the RP comes into the vitreous cavity, it produces inflammation over the surface of the retina, leading to the PVR formation. If there is early PVR and the patient is young, the patient is phakic, the vitreous is more jelly type, not liquid type, because of the aging process, it will become liquefied. And if a break is there, it's an indication for the external procedure. What is the benefit of external procedure? A single procedure is performed. The vitreous, the patient own vitreous is there within the vitreous cavity. What we will be doing in the pars plana vitrectomy, that we will be injecting silicone oil or gas into the vitreous cavity, because in pars plana vitrectomy the vitreous need to be removed. Then we can treat the retinal detachment or retinal break. If the vitreous is removed and the pars plana vitrectomy, this vitreous need to be replaced with another substituent. That is, which can be a gas, can be silicone oil, can be heavy liquid, or anything. But an external approach, because we are just applying a plomb or indentation on the external surface of the sclera to indent the retina, the patient own vitreous is within the vitreous cavity. It has not been disturbed. So a single procedure is performed, and if the retina gets detached, gets attached, no other procedure is needed. But in pars plana vitrectomy, if the vitreous is removed and we put silicone oil within the eye, that oil need to be removed. The oil is having complications like the intraocular pressure can get raised, cataract will be formed because of the silicone oil, multiple surgeries will be needed, and sometimes the silicone oil get emulsified and it will come into the anterior chamber and also block the trabecular meshwork. And once the silicone oil gets emulsified, it's very difficult to remove. Again, you can see the buckle is placed at the equator of the eye. It will push the surface of the retina inwards and reduces the vitreous traction, and also indentation is produced, and then the subretinal fluid is usually absorbed by the retinal pigment epithelial cells. And with the passage of time, and when we apply the cryo to that break, the break is closed, and when the break is closed, the remaining subretinal fluid is usually absorbed by the RPEs, and the retina gets attached. This is the encirclement band. This is the encirclement band. It is stitched over the equator so that it should not slip posteriorly or anteriorly. It will remain in place. And then it is tied as needed, because we can pull it as much as we want, but we are taking care not to increase the intraocular pressure. So this is the break, and when the encirclement band is passed, the cryopexy is done. So what will happen that the break is closed and the retina gets attached, and the fluid is usually, it can be drained, and sometimes a non-drainage procedure can be performed because this fluid is then absorbed by the retinal pigment epithelium of the retina. This is another approach and most commonly performed approach nowadays, because and the developed world, because of the advancement and the instrumentation. Most of the people are going for the pars plana vitrectomy, and this procedure, with the passage of time, surgeons are the threshold for the pars plana vitrectomy increases and that for the buckling decreases. But still in Pakistan and India, we are going for this procedure for external procedure because of certain advantages over the pars plana vitrectomy. So this is the pars plana vitrectomy, also called three ports pars plana vitrectomy because three ports are formed. These are the superior ports and one is the inferior port for the infusion cannula. Always keep in mind all the procedures for the posterior segment of the eye is done to the pars plana. Usually, this is the most common question asked in the exam, that how you can approach to the vitreous cavity, how you can do, from where you can do retinal detachment surgery, how you are injecting intravitreal steroids or antibiotics or any sorts of injection or in TVTF. All this is done through the pars plana. Why the pars plana? Because this is an area where the retina has not started and the ciliary body is not there. So it's the safest area to approach from here. And it is usually, what is the location of the area? It is 3.5 millimeter from the limbus. Usually we are putting 3.5 millimeter from the limbus in pseudophakic patient. And if the patient is phakic, then 4 millimeter from the limbus area. So in pars plana vitrectomy, one in the infusion port, because we will be putting a cutter from one this the cannula, and we'll be putting light from the other cannula. So with the light we can visualize, and with the cutter we'll be cutting the vitreous. If we are going to cut the vitreous, it need to be replaced by the fluid, so that to maintain the pressure within the eye. Like in one port, the light pipe is entered, and in the other port, the vitreous cutter is entered, and from the other, continuously the infusion is coming into the eye. So if you are cutting the vitreous, the infusion is replacing that cut vitreous, and the tone of the eye is maintained and pressure of the eye is maintained. What we will do, the first thing is we need to remove all the vitreous. Let's suppose if there is a break, we need to remove all the vitreous. Then we need to drain the subretinal fluid through suction from the cutter. And when the subretinal fluid is drained, then we need to replace this vitreous that has been cut, because there will be fluid and the fluid is not having tamponading action because the break is there. We need something to have some tamponading effect on the retina for some time, so that when the break is closed, the subretinal fluid is absorbed and the retina gets attached by fibrosis. For that, we need to put either gases or silicone oil. And sometimes, if there is no retinal detachment and we are doing it for the vitreous cavity hemorrhage, the vitreous is removed because the hemorrhage is within the vitreous cavity, then the laser is done within the vitreous cavity, or the laser is done on the retina. And sometimes we are leaving the fluid inside the vitreous cavity if there is no break in the retina. But if there is a break in the retina, then it must be replaced either by gases or by the silicone oil. Thank you very much. So this was about the rhegmatogenous retinal detachment. Next time we will discuss the exudative and the tractional type of retinal detachment, and the treatment is almost similar. Because whenever there is break in the retina, it need to be closed. And for the closure of the break, if it's a tractional retinal detachment, we need to remove the traction. If there is only a break is there because of, by the process of the posterior vitreous detachment, a break is formed in the retina, it can be treated either by external approach or by the internal approach. The external approach is called scleral. The scleral buckling are the day's procedure, drainage, air, cryo, and explant. And the second one procedure is the pars plana vitrectomy. Through the cutter, we remove the vitreous from the vitreous cavity. Then we close the break of the retina and also remove the traction over the break if there is any vitreous that is removed. When the retina gets flattened, then we need to surround the break with the laser spot so that the fibrosis is formed and it should not reopen again. And if then the vitreous is removed, we need to replace the vitreous either with the silicone oil or with the gas. If it's an uncomplicated surgery, then we can put gas within the eye. But if it's a complicated surgical procedure, complicated retinal detachment, then it's important to put silicone oil, because the gas will be having a short-acting tamponading effect on the retina, whereas silicone oil will be there for a longer period of time, but the silicone oil need to be removed. The drawback of silicone oil is that, and the gas will absorb with the passage of time, so second procedure is usually not needed. But in the silicone oil, definitely it needs to be removed because there are certain complications associated with the silicone oil, like raised intraocular pressure, emulsification of the silicone oil, decrease in the visual acuity within the silicone oil. The complication with the gases are that the patient cannot fly, like the patient cannot, the patient is restricted from the air travel because if the patient is going up, because that is a gas, it will expand further, and sometimes the pressure is too much raised, leading to the vascular occlusion. But if the patient is not planning for air travel, then we can put gas. But if the patient is want to travel, then we must put silicone oil because silicone oil is not going to expand with the air travel. So there are certain more a few more complications related to one option and the other, but definitely it depends upon, we need to discuss the options with the patient and the requirement of the patient, and also the need for the surgical intervention, that which type of surgical procedure we are going to do. If you are thinking that it's a complicated detachment, then it's important to put silicone oil because the complicated detachment is not going to be treated with the gas. Even in developed world, they are even treating the complicated cases with the gases as well. But in our setup, because our system is not that much established like that of the developed countries, so we are more prone towards the silicone oil rather than the gases. So we will continue with it next time as well. And thank you very much.